first component is helping patients to understand that they're not alone in their symptoms. So I think, even in the traditional healthcare system, we really like to have definitive classifications for things. And because, as I discussed, BV has been oversimplified, I think patients whose symptoms don't classically fit BV have been told, well, maybe you don't actually have BV. Are these symptoms just in your head? Are you sure they don't actually feel like X, Y, and Z? And so I think adding more nuance helps patients feel understood and included. And then I think on the flip side, it helps us understand the science even better. So we can ask our patients and see what they're experiencing and then match that with certain bacterial pictures, if that makes sense. So we're going to learn more from that. So I think it's really important, I think, for us to try to serve our patients well, not just from the treatment perspective, but from the understanding perspective. If like we can say to somebody, it actually makes sense that you're experiencing burning because we see these particular microbial signatures. Somebody's gonna be like, wow, it just feels validating to know that there are other patients just like me, that this is a known pattern, and that like this burning is not in my head because I went to like 5 other doctors before this and they told me I was crazy. So I think that's going to be really important and validating. And the second part, as you say, is does this inform treatment? So, like another hypothesis that I would have would be for the biofilm producing BV, I would expect to see in our data that patients perhaps who tried boric acid prior to doing a vaginal antibiotic course might have a better outcome. We think of boric acid as a reasonable way of breaking up that biofilm before introducing the antibiotic into the vaginal ecosystem. So I would suspect patients who did that would have a better outcome. Similarly speaking to the typical BV picture where you have lots of BV-related bacteria and very few healthy bacteria, I would expect our patients who used vaginal probiotics after their antibiotic treatment that contain Lactobacillus crispatus, like the probiotics we prescribe to patients, would also have a better outcome because we're helping to boost that healthy population. So I have these hypotheses about what I expect to see working for these different populations, and we'll see if those turn out to be true. But I think it's going to be really meaningful for patients and for clinicians to understand these nuances and how they play into outcomes. Because historically, the recurrence rate for BV can be over 50% by the time you hit 3 and especially 6 months out from initial treatment. It's such a high recurrence rate. We know that male partner treatment plays a role in that recurrence rate, but we also already know that exactly what treatments people employ play a role in this as well. Overall at Evie, we actually do a much better job treating BV. Like our recurrence rate at an average of 4.5 months out from treatment is 30%. So it's substantially lower than in the community. And this is even before we defined these different BV subtypes. And I think that's because we tend to have a really comprehensive approach. If we see biofilm producers, we're prescribing boric acid prior to a vaginal antibiotic. For people who have low lactobacillus or healthy bacteria in their vagina, we're prescribing vaginal probiotics with lactobacillus crispatus present. I think that really helps. And this data even predates when we started offering male partner treatment as well. And so it's going to be really interesting to see how this filters into the different subtypes and what else we can learn.